Each year in the U.S., nearly 100,000 women are diagnosed with gynecological cancers, including ovarian, uterine, cervical, vaginal, and vulvar cancers, according to the National Cancer Institute. Prevention, early detection, and high-quality care can make life-saving difference. We're excited to share insights from Dr. Christy Haygood, a gynecologic oncologist with St. Dominic's Gynecologic Oncology Associates in Jackson, Mississippi. In this conversation, Dr. Haygood shares practical ways women can reduce their risk of developing GYN cancers and highlights key symptoms to watch for. She also dives into the future of cancer care, including personalized treatments, tailored to the individual, and innovative breakthroughs like molecular level diagnostic and clinical trials. These advancements are now more accessible to patients in Mississippi than ever before. So with that, let's dive into our conversation. Welcome, Dr. Haygood. Thank you for joining me to talk about reproductive cancers. I'm excited to learn more about your specialty and what women should know about these types of cancers.
Yeah, thank you for having me. This is a great passion of mine. It's just to make sure that all of our women out there and our men who love women are able to help them through symptoms and know where to go when they need help, and so that we're all just aware of how to take care of these women.
Well, let's start with a bit about you. Tell me about your background and your work with St. Dominic's.
Yeah, absolutely. So I have been here for the last 8 years. I am a Mississippi native. I grew up just about 45 minutes south of Jackson. Went to a very small, tiny town, then went to Mississippi College. So stayed here, did medical school in Mississippi, and then was actually offered the opportunity to do a 4th-year medical student rotation here at St. Dominic's, which is far too long ago now to think about. But I did that actually with my current partner, Dr. Sego. So we first met almost 15 years ago, which is amazing now to look back. But I went to medical school, confirmed that I did want to take care of women. That was kind of the first step, was I really felt drawn to women's healthcare, and then found that I love doing surgery. I love taking care of doing chemotherapy and taking care of cancer patients, and really found joy in sort of that cancer care where women are probably at one of the scariest times in their life, and where my faith has played a very large role in that ability to meet people where they are at this scary moment and walk them through it. So I've been here for 8 years with my family moved back here with me. So I moved away as a single lady and came back with a husband and 2 children, had one since then. So we are busy, but very happy where we are and glad to be able to provide a unique service to the women of Jackson.
Well, thanks for sharing that background. St. Dominic's is lucky to have you as part of the team. Can you help us understand a little more about your specialty, and what does a typical day in your clinic look like? What is it like?
Yeah, absolutely. So I get this question a whole lot. What is GYN oncology and what do you do? So for the most part, we take care of women that have cancers: uterus, cervix, tubes, ovaries, vagina, peritoneum. And that training involves doing OBGYN first. So we do OBGYN, but then we sort of give up the baby delivering and move into cancer care and advanced pelvic surgery. So we do a fellowship for 3 years to be able to do that. And we give chemotherapy to our patients. And then we also do surgery for the GYN cancers. And then because we do a lot of pelvic surgery, we do a fair number of benign surgeries as well, just sort of complex pelvic surgery. A typical day for us, so my typical week is I have clinic on Mondays and Wednesdays, and that's where we see new patients who have been newly diagnosed with cancer, who have a pelvic mass, potential for malignancy that we are going to evaluate. Or we see recurrent patients, or patients who are just in surveillance, who have previously had their surgery. They're currently on chemotherapy. And that's kind of what a Monday and Wednesday looks like for me. Tuesday, Thursday are my operating days, and then kind of fill in whatever we need to get done. So paperwork, or following up on pathology results, following up on labs from the day before. Surgery is typically starting around 7:30 in the morning, lasts until we're done. So usually between 3 and 4 o'clock is typically our day.
Yeah, you can't rush that.
No, it takes how long it takes, and that's where we are.
So you mentioned a few types of cancers that fall under gynecologic oncology. Can you explain the difference between them and which ones are the most common?
Yeah, absolutely. So I'll give you kind of a brief overview of the typical things that we see. So uterine cancer, endometrial cancer is very common in the South. It's typically seen in women who are post-menopause, typically presents with bleeding. Usually that's abnormal for women and they think, oh gosh, I have to get this looked at. I'm now bleeding where I used to not be bleeding. I need to have this evaluated. And so a lot of those uterine cancers or endometrial cancers are picked up fairly early, typically stage 1. Those patients usually require just surgery alone. A handful of patients will then have a lymph node biopsy or a lymph node dissection that shows an advanced stage and they will need additional treatments. But the majority of those patients have a stage 1 limited cancer that has excellent survival rates. We take care of women that have ovary cancer. Ovary cancers are kind of lumped into a group with fallopian tube and peritoneal cancers. Those cancers all have sort of similar origin. They have similar treatments. And are treated really with a combination typically of chemotherapy and surgery. And in that order depends on what stage we present at, what sort of disease is present at the time patients show up, and then their medical comorbidities. So how stable is a patient to be able to undergo surgery goes into our thinking for that kind of treatment. A lot of those cancers, while I'm talking about that, a lot of those cancers are associated with genetic mutations. And so things that we have now that we didn't have, when I started doing fellowship 10, 8, 9, 10, 11 years ago, we really were just kind of learning about what is an inherited genetic mutation that puts patients at risk. And now we know so much more about how many genetic mutations are out there that particularly put women at risk for breast cancer, for ovarian cancer, fallopian tube, peritoneal. And so part of our job now is not just to test for those mutations in the patients that we take care of, but also to let them know that, hey, if your mom had ovary cancer, if you've got 3 aunts, a grandmother, a mother with breast cancer, you should consider genetic testing, because if we can diagnose a genetic mutation that puts you at increased risk for cancer, then we can do different things to prevent that cancer from happening. And honestly, the best cancer treatment is prevention. And so for those patients with ovary cancer, fallopian tube, peritoneal, sometimes what we're able to do is do a risk-reducing surgery when they're done having children, when they're out of their active reproductive years, and remove the tubes and ovaries and significantly reduce their risk of dying from those diseases, which is just amazing. And I'm so thankful to be on this side of treatment in the era of taking care of those patients, because we used to not know those things. And then one of the other cancers that we take care of is cervical cancer. And so cervical cancer really in this day and age is mostly a preventable disease. With the advent of the vaccine, for the brand name is Gardasil, but the HPV vaccine, which now prevents against or produces antibodies against 9 different HPV strains. So it's called a non-valent vaccine. It's available for anybody between the ages of 9 and 45. Now, the best protection for that kind of HPV virus and then the virus producing cancer in later years, the best protection starts when people are younger. We just get a better immune response when we vaccinate earlier. And so that can start at age 9. And so between 9 and 15, you get 2 vaccines, about 6 months apart. Over age 15, you get 3 vaccines, and that's really just to produce an adequate immune response so that we can then potentially prevent those cancers from happening. But those cervical cancers typically would start with an HPV infection, and that HPV infection leads to abnormal pap smears, cervical dysplasia, cervical precancer. And that's why we're doing pap smears. That's why we're looking for the HPV virus, so that, again, the best cancer treatment is prevention. And so if we didn't get vaccinated, then hopefully we can pick up those precancer lesions and treat them with things like cold knife cone biopsies or LEEP, or even potentially a hysterectomy if that's what's needed for those patients.
Something you mentioned earlier about the prevalence of these cancers in the South caught my attention. Can you tell me a little more and elaborate on how where we live might influence some of these risks?
Yeah, absolutely. So, there are certain things that are genetic mutations that are inherited. And so, there are certain populations across the world, Jewish populations in particular, who are at higher risk for some of those inherited mutations. Now, some of the cancers that we see here in the South, like endometrial cancer, can be genetically mutated, but that's also some of our environmental factors. And so part of that is obesity. And as we know, here in the South and Mississippi particularly, obesity is a large part of some of the issues that our patients deal with. And that obesity increases the risk for endometrial cancer. And so, that's part of why these things are more common down here. The other, things about cervical cancer is really if women are able to get good access to care, they have good screening, follow up like pap smears, potentially we don't develop those cancers. But when so many of our patients live in rural areas, they have decreased access to care. And even if they get a screening, they may not have access to treatment due to rural locations or not having funding or, just different socioeconomic issues that our patients deal with. We may not be able to get them treatment when we're doing these screening things. And so I think that does increase some of our risk of these cancers, not necessarily always a genetic issue, but because of some of these socioeconomic issues that we're not able to get to quite yet.
It's so true that a bigger picture of our health includes more than just genetics.
Yeah.
And so circling back to prevention, what steps can women take to reduce their risks? And are there lifestyle changes that can make a big difference?
It sounds, it's funny, a little funny now because people will always say, well, you should eat a healthy diet and you should exercise. But that's so true. And it's not, I honestly believe that we were not designed to eat the way that we currently eat. So we really were designed to eat less processed foods and more whole foods. And don't get me wrong, I will love a fried okra and a fried squash, and you really can't put them in front of me without me eating them. But we just have to keep in mind that those things should be done in moderation. And it really living an active lifestyle. And we were meant to work. We weren't meant to really be sitting around all the time. And so if your job is mostly a sitting job or a sedentary job, being active, taking a 30-minute walk at night really can even be enough just to keep your heart rate up, to reduce some of those risk factors that increase cancer risk. Yeah.
And of course, annual exams are key, right? Don't skip the pap smears.
Yeah, absolutely. And I always say this when I talk about, I think one of the most important things that women can do is to have a provider that they trust. And so, however you get to that provider, wherever that provider is, but somebody that and importantly, going along with that is paying attention to your own body and knowing, okay, this is normal for me. Hold on, this is not normal for me. And so when women start to notice, oh, hold on, I've had that same pain every day for the last 2 weeks, and I took some ibuprofen, I took some Tylenol, it didn't go away. I really need to talk to somebody about this. And then to know that if you continue to have the same problem, to keep following up, keep going back and saying, no, doc, I really need you to look at this. I'm really concerned about this. And just having someone that you can go to help you work through those, any issues that you're having. And of course, absolutely, pap smears, mammograms. We do those screening things because they pick up on precancers. And so if we pick up on precancers, hopefully we never develop a cancer, but we have to be able to go and get those things done.
That's such a good point, to be an advocate for your own health and speak up more to be sure you get your questions answered.
And even your family members, I think our families play a big role in that advocacy too, because I certainly have patients every day that'll, the sister or the daughter, the aunt will sit there and say, doc, I told her to get that looked at. I really thought she needed to have that looked at. And so to have family members, to have a provider that you trust, and people who advocate for you and support you in getting those things worked up.
So you mentioned pap smears and mammograms earlier. Could you explain the role of these and other recommended screenings and how they may help in early detection?
Yeah, absolutely. And I think we learn more really every year. So, pap smears were actually invented in the 1930s, which is, obviously prior to my lifetime, and you guys too, not some of our patients or some of the people who will be listening, but, pap smears really do a great job at picking up on, precancerous lesions. And so what we're looking for are things in the cervix that would indicate a precancerous lesion so that we can then treat it. And that's really the goal with any screening, is that we pick up on a pre-malignant lesion or something that is suspicious so that we would be able to then take care of it before it became a cancer. And so that's what we find on mammograms. That's why it's very important to follow those screening guidelines. And if you're getting them every year, sometimes it's every other year, kind of depends on family history or past baseline. And then making sure too that you follow up with that. And I think what's important for pap smears too, is I talk about this all the time, is we don't just do a pap smear now, we do an HPV test. So I mentioned HPV earlier, talking about how HPV is a virus that causes cervical cancer, causes about 98% of the cervical cancers here in the U.S. It's also associated with over 90% of head and neck cancers. And so, when we are screening for HPV with a pap smear, we are looking for those patients who are at risk of developing a dysplasia or a precancer. And so we know that people who have persistent HPV are at highest risk for developing that. And so those are the patients that when I communicate with them, I want to be sure to say, hey, we saw this virus. We just want to be sure that you're not going to develop a cancer. We might do some additional follow-up. So for a pap smear, if you had an abnormal pap smear, you might get what's called a colposcopy. That's where we use essentially a microscope to look at the cervix. We put vinegar, and I always say this, which I think is so weird, and I've never looked it up. Who thought this would be a good idea? Oh, let me put vinegar on the cervix and that'll show me the abnormal cells. Isn't that crazy?
That is funny. What a test.
And maybe, right? Like maybe eventually I'll look up how that actually happened, or maybe somebody will call in and say, oh, I know that story. But it works. And so what we use the vinegar on the cervix to help us dehydrate some of the normal cells, helps us find the abnormal cells. So it's just an interesting little phenomenon, but that might be something that you'd have done if you had an abnormal screening test. If you have a mammogram done, and let's say this happens all the time when people are young. So we have dense breast tissue. We pick up on things that maybe it's your first mammogram. Maybe you have something new that's found from before, and you have to come back, and you have to come back and get an ultrasound, or they find something that's concerning and we do a needle biopsy, or we need to do an excisional biopsy. And I think it's important too that women, and for everybody, but the important thing to know about a screening test is that it's a screening test. And so there are going to be times that we find abnormal things that are not cancer, that are not worrisome, but it's a screening. And so we have to follow up on them. And if you have something abnormal found on your screening test, to just make the effort to get that abnormal thing or whatever it was followed up or worked up appropriately. I just hate to find patients, and I see this from time to time, that, we'll have let's say we have a cervical cancer, and they'll say, well, 5 years ago, I had an abnormal pap smear, and then COVID happened and I didn't get it worked up. And so, I hate that. I hate that we as providers will forget to call people. We will miss an appointment. And so again, that goes back to advocating for yourself and saying, hey, I know I had this abnormal test, and I know I need to make sure it's worked up, and how can I get that done?
Thanks for the rundown of screenings. Can you clarify the age recommendations and how frequently they should happen?
So it's interesting you asked that. So pap smears are sort of a moving target. There are a lot of different recommendations, and it really depends on kind of your past history. And then we are shifting, in general, all societies are kind of shifting to a primary HPV screening alone, which actually the FDA just approved HPV self-testing. And so those do have to be collected in a provider's office, but it would eliminate a provider having to use a speculum to obtain a sample from the cervix. And so it actually allows a woman to do a self-collection of an HPV test, which, I'll go back to the question in a second, but I think that's really, I think it's a great step in the right direction, because we know there are women who have had traumatic events who really don't tolerate a pelvic exam, but they still need to be screened. Or they don't have time, or there's a provider who's just not comfortable doing a pelvic exam, and the patient can't get to somebody who is comfortable doing that. And so an HPV self-collection is a great way for us to be able to reach those people who then need additional screening, because we know that if your HPV test is negative, the risk of developing a cervical cancer is really very, very low, almost 0%. So, let's go back to, going back to what you asked me about age. So, for Pap smears, you really should not start them before 21. That was what we've traditionally thought about cytology. That age is probably going to change pretty soon. Really about 25 is probably where that's going to start. And the reason for that is we know that so many people in their early 20s have an HPV infection. But the important thing to know is that just because you have an HPV infection does not mean you are going to develop cervical cancer. In fact, over 80% of Americans have had an HPV infection. Over 80% of Americans do not have a cervical cancer, nor do they have a head and neck cancer or a pharyngeal cancer, which is what we see in men. So what we know is that over 80% of people are exposed to HPV, have an HPV infection. The vast majority of people clear it within 2 years. So what we were finding was that when we were screening these younger patients, we were finding HPV, but we were finding something that was never going to develop into a problem. And so this age has moved a little bit from 21 to 25. That's probably really where I think most societies are going to land with recommendations. And so that really would then be from 25 to 65. And also, depending on history, have you had a history of high-grade dysplasia? Did you have a precancer? Have you had a cancer in the past? All of those things can change when you stop doing Pap smears for women. And so, did you have a hysterectomy? What did you have your hysterectomy for? And so a little bit of a moving target, but in general, between 25 and 65, you should have some sort of cervical screening. And whether that's a Pap smear, whether that's an HPV only test, depends a little bit on age and past history.
I think this will be a burning question for a lot of people. What are some of the common symptoms women should watch for? I know we have to listen to our bodies and notice what's normal, but how can we know when something isn't right?
Yeah. So great question. So, I'll say it's kind of a tricky thing about ovary cancer is that it's really quite silent and the symptoms are very vague. And so when we talk about ovary cancer, that's really why I think it's very important for women to be aware of their own body and to be advocates for their own health. So if they start to notice, I've had this pelvic pain, I have this bloating, I'm gaining weight, my stomach's getting bigger, I've got a kind of fullness and bloating, and I'm just not digesting my food the way that I used to. While those sound very vague, and they could just be associated with diet changes, with age, with menopause, all kinds of different things, we just want to be sure that we've had them worked up. Now, I will be very honest and say that I am biased. And so until bloating and abdominal swelling has been worked up, it's an ovary cancer. It's not. The truth is it's not. It's only about 1% of the time going to be an ovary cancer, but I'm highly suspicious. And so I just want people to be advocates for themselves and know that they need to get those things evaluated. Now, a cervical cancer is typically going to present with some increased bleeding. Occasionally pain, that's typically a later sign of a cervical cancer. Usually though, women will have either bleeding in between their cycles, they'll have bleeding after intercourse, or just sort of an irregular bleeding pattern. And that just would be something that we would want to have worked up. And the same for endometrial cancer. So earlier I mentioned that most of the time endometrial cancer is diagnosed in women who are postmenopause. And so they've stopped having cycles and then they restart cycles, or they start having bleeding after their cycles. And so they know that's abnormal and they come get that worked up. But I've also, I probably in the last 5 to 6 years have seen an increased number of younger women diagnosed with endometrial cancer. And so whether that's obesity, whether that's having anovulatory cycles, because that's all feedback from different hormones, having sort of an imbalanced hormone function inside the uterus can develop some of those endometrial cancers. So, of course, like I said, I'm biased, but anyone who's got irregular, unexplained bleeding needs to have a biopsy. They need to have an ultrasound to explain why those things are going on, and just know that it's not a cancer. And once you've ruled that out, then you can work up everything else.
I think that's really great advice. With so many factors affecting women's health, it can be tough to distinguish normal changes from potential red flags.
Right.
And what I'm hearing you say is that if you have even just a little bit of a suspicion, it's best to bring it to your doctor to get it checked.
Yep. And that's, like we said, that's why it's important to have somebody that you trust, and that will let you advocate for yourself. And so that you know that everything is being worked up appropriately.
I have a question that may seem basic, but I think it's important to clarify. Do you need to have endometriosis to develop endometrial cancer, or are they separate conditions? Can you walk us through that?
You're exactly right. They are two separate entities. And so endometriosis is essentially where the endometrium, the lining of the uterus, has come out of the uterus. So for whatever reason, either it comes out the tubes, or it just grew there abnormally, however that has happened. But those can also cycle just like the inside of the uterus can. And so when you have essentially a cycle inside your abdomen around your ovaries, that is painful. And so that bleeds inside the abdomen, which hurts, which is why endometriosis can hurt patients, or why they have pelvic pain with that. But some of those processes that are kind of a hormone imbalance that sort of can feed endometriosis, and then can sort of feed what's going on inside the uterus, can exist together. And then there are some types of cancer that can develop inside the endometrial cavity that can also develop in the endometriosis lesions. And so like a clear cell cancer, or an endometrioid type of cancer, those things can develop. But they certainly can be two separate entities and not necessarily related.
That makes sense. Can you talk a little bit about the diagnostic process? So when someone is diagnosed with a gynecologic cancer, what can patients expect as they move through that journey?
Yeah, absolutely. So I'll kind of start with probably one of the more common things that I'll have come in for people who don't have a cancer diagnosis when they come in is a pelvic mass. And so let's say they came in for their annual exam. Their practitioner thought, something feels a little funny on your exam. I think we need to get an ultrasound. The ultrasound showed an ovary that looked potentially abnormal. And sometimes those things will look like a complex mass. Sometimes it looks like a complex cyst. Sometimes it's a solid mass. Sometimes it's both ovaries. And so I'll get a fair number of referrals for that complex pelvic mass. So what our process then would be, whether the patient has had a CT scan, and that's often something that we will do afterwards, a CT scan of the abdomen and pelvis. We might do some blood work. So some of the tumor markers that we use, which are not great for ovary cancer, if we're working up an ovary mass, is a CA-125. We use that as a blood test, and it's a serum marker. It's just not a great one. So it measures kind of peritoneal irritation, or irritation inside the belly. Lots of things can make that happen. A cyst itself, a mass, if patients are ovulating, if they're having cycles, if they have fibroids. So anything non-cancer can make it look like that. But that might be a test that we would check. And then typically if it's a pelvic mass and the patient is a reasonable surgical candidate, if their CT shows either advanced disease or just a mass limited to the ovary, would kind of depend, is this something that we would need to get a biopsy of before we go to the operating room? Or is this something that we would need to go ahead and take to the operating room and take out? We don't love to biopsy the ovary. I describe it often as the ovary, like a cyst looks like kind of a water balloon. And so if you think about a biopsy, what we're typically doing is sticking a needle into something. And if that is an ovary cyst or water balloon and we stick a needle into it, then it pops. And so we don't, if that is we can do that if that is a last resort, but we do not love to do that. And so really, if it's something that's worrisome, what we would prefer to do is really just take that whole ovary out. And so that would typically be done operating room, and then whether or not we need to go ahead and take out uterus or other ovary, or do what's called a staging procedure. So that's where we take out biopsies of the omentum, the other parts inside the belly, like the peritoneum, or if there are other things that we think are involved with cancer, or that then we get to the operating room and we find out our cancer. Then a lot of times we'll go ahead and take care of all of that while we're there. And sometimes we see that on the CT scan, there are findings that are very worrisome for an advanced cancer. And so we call that carcinomatosis. That's where it looks like there are tiny little flecks kind of throughout the abdominal cavity. And if we see that, then a lot of times we will consider getting an interventional radiology biopsy. And so we have a whole big team here that helps at St. Dominic's that help take care of these GYN cancer patients. And our interventional radiologists are a big part of that. And the way that they help us is not just by reading the scans that we do or potentially getting a PET scan and helping us look at those images, but also by doing biopsies for us and being able to use a CT scanner to directly biopsy something that we think is abnormal that's maybe outside the ovary. So if we think there's something in the liver, there's something along the diaphragm, there's a mental lesion, a lot of times we'll get a biopsy of that. If that confirms a cancer, then we might think about, okay, is this something that we can go to the operating room, remove all of the cancer at one time? Or is this a patient that's going to need chemotherapy first? And so the goal with chemotherapy at that point would be a neoadjuvant chemotherapy, where we would use chemotherapy to reduce the total volume of disease so that then when we went to the operating room, we would be able to take the rest of it out. Now, that's kind of for a pelvic mass, other or potential ovary cancer. If we had things like an endometrial cancer, a lot of times those patients will come in with a diagnosis of endometrial cancer. And so they've had bleeding, they've had a biopsy, or sometimes those patients will have had a dilation and curettage or a DNC in the operating room. And then they'll come into the clinic with that diagnosis. And so at that point, then we look at what the diagnosis tells us, and it kind of is based on grade of disease, and then what other findings from the ultrasound. Do we need to get a CAT scan? And again, a lot of times we will get that same CT or CAT scan of the abdomen pelvis. And then for endometrial cancer, think about surgery. And so we do a lot of our surgeries minimally invasively, so laparoscopic. And then based on what we find at the time of surgery for an endometrial cancer would be remove uterus, cervix, tubes, ovaries, and then some lymph nodes. And so we would put all of that together at the end, and they'd come back to see us in a couple of weeks and talk about the pathology. And so that would include the lymph nodes, and then based on the findings from the tumor itself, do we need to do any additional treatments like radiation or chemotherapy?
You mentioned that treatments for gynecologic cancers are highly personalized. How do you approach tailoring care to each patient's needs?
That's probably one of the biggest parts of my job is I get to do surgery, and I get to take people from, hey, this is your diagnosis. Hey, we're going to operate on you. We're going to take this out. And then I have to put all the pieces together to decide what is best for you. And we have come so far in cancer care now. And I really think, and I've said this for a few years, so it's still headed that direction. We're not there yet, but I think it's going to come true. So I'll go ahead and say it again. I think that we will get to a point where we treat cancers based on what the molecular signature is. And so what do I mean when I say that? What I mean is from a very basic level, there is something that goes wrong in a cell to develop into a cancer. And so when that cancer, when our cells have been copy of a copy of a copy of a copy, every chance there's a copy, there's a chance for an error. And so every potential for an error is a potential for the cell to either keep growing, to grow abnormally, to forget how to die, to recruit additional blood vessels, to recruit additional endothelial cells or other growth factors to help it grow further. And so what we can now do for so many different things is pinpoint exactly why that cancer happened. And then if we pinpoint why that cancer happened, for some things, I feel like we're a little behind in GYN, but we're getting there. We can directly target that mutation and then treat the patient based on that. So it's, we've shifted a whole lot from, hey, these are these chemotherapy, really cytotoxic poison that we give people that go all over the body and they potentially harm all kinds of different cells in the body to where we can now say, hey, your tumor had this specific signature, and we think this is exactly why your cancer happened. And now we're going to give you a drug to stop that. It's just amazing, right? I mean, it's amazing. Yeah. And so, that's a lot to keep up with. And I'm always having to look that up. I'm always having to say like, okay, hold on. I got to look at your exact tumor. Hold on. You have these mutations. Let me look at exactly what that is. But then to say, hey, I think we can forego chemotherapy, or what we know now is that your specific mutation would tell us you would respond best to radiation. Your cancer is limited to this area. We can do radiation for this. And that's all sort of in the art of medicine. And it's not always a cookbook, and it's not always one answer fits all, but there are just various things about the patients. And, I have patients who come in and they're just like, Doc, I'm not going to get chemo. So whatever you need to do, I'm not going to do that. And that's okay. That's, I take care of a fair number of older ladies and my advanced ladies. And I always tell them, look, this is your choice. Okay. So if you're 32, I'm probably going to say, okay, you're 32. I really need you to do the treatment. If you are 82, ma'am, you get to decide. So you have lived a nice long life, and whatever you want to do at this point is fine with me. Now, if you're 82 and you live by yourself and you were out gardening last week and you shop for your own groceries and you go to church twice a week and you drive the bus for the old folks, I'm probably going to ask you to do chemotherapy. It does. It just depends on, hey, what is your current quality of life, and what can I do to preserve your quality of life, maintain that life as long as you want it to be with good quality. And that just fits into the art of how can I prolong your life with good benefit and with meaningful life? And how can I get your family to understand that too? Which is, and this is not really what you asked me, but I like to talk about this too. It's part of the beauty in my job is helping people when their life is not going to be as long as they wanted it to be, or as long as they expected it to be. There are people every day whose life is cut short immediately, and with no warning, with no expectation that was going to happen. And despite how much progress we have made in cancer care, unfortunately, a lot of my patients die. And that is a reality that I walked into knowing I can help a lot of people. But there are some people that I can help not by treatment, but by helping them see that treatment is not right for them, or focusing on symptom management and managing the time that they have left. And that has a lot of beauty for me in being able to say, I know where you're coming from. I understand that this isn't how we thought it was going to be, but this is the time we have left. And what are the things that are important to us? And what are the things that we can do? And who do we want to spend our time with? And I think there is beauty in being able to do that, and to help patients see that sometimes not getting treatment is what's right for them.
That's such an inspiring approach to care, recognizing the whole person. How do you balance aggressive treatment with comfort and quality of life, especially for those in more advanced stages?
Yeah, I think too, it's, my faith makes that easier. And I'm so blessed to work in a place that lets me share my faith as if patients want to hear about it, or if they want to pray with me, or they want me to pray with them. And I think when we face end of life, that is very important. And so being able to share my faith with people, or having them share their faith with me, and hey, I understand where I'm going after this life, and I'm okay with that. And that does make it easier.
It must be incredibly rewarding to walk with patients through their journey. And one thing you said about St. Dominic's and the cancer services that you provide there, you mentioned how it may start with investigating one area, but if cancer has spread and there are other considerations that need to bring in other subspecialties, that's a big reason why patients should consider a comprehensive care center like St. Dominic's, because you can seamlessly transition to larger multidisciplinary teams if need be.
Yes. So there are several things that I think are very unique about our institution here. My partner, Dr. Seago, had established really a very good working flow, a good relationship with a lot of different doctors. And so he also established our research program here, which I haven't touched on yet, that we're allowed to do. And I'm really grateful that the institution lets us still do that and provide support for us to run. And we're the only people in Mississippi who have GYN cancer trials open, which I think is amazing. And we actually currently have trials for endometrial cancer, for cervical cancer, for ovarian cancer. And I think that's incredible. And that's just a part of that team that we have research staff. We have staff from Baton Rouge who help with our institutional review boards, with our consent forms, with doing some of our budgeting for our clinical trials, which is just amazing. And then, this is a relatively small institution, but there's really not anything that I don't have access to here. And so if I need a urologist, well, I've got one in my phone. Hold on one sec. Let me text my urology friend downstairs. Let's get you hooked up. Let's see what we can do. Okay. We need general surgery. All right. Hang on one second. Let me see who's up in clinic today. The patients need to have radiation. Absolutely. It's right across the street. And so you'll come up to see me in the clinic. We'll send you right across the street. You'll love the guys over there. Here's who we work with all the time. Our cancer navigators are the same people. If you need a cardiologist, we've got that. And so we are big enough that really we have such a good team, and our interventional radiologists are incredible. They're so helpful. And we really are able to do things in a timely fashion to get patients taken care of. It makes me honestly really upset when I hear people talk about, well, my Aunt Betty had cancer diagnosed and she's not been able to see a doctor for 6 weeks or 8 weeks, and they got her in, but they can't do her surgery for another 3 months. And that's just not the way that we have operated here. That's just not the way that we have felt like provides the best care for people. And our institution certainly has been very supportive in, hey, if you need this, we're going to make it happen, and we're going to find a way to support the work that you do. And I've been very thankful for that. There's, our infusion center is right downstairs. When, is it in 2 years? Last year, there were huge national chemotherapy shortages. This was really a pretty scary time across the nation, where people were being diagnosed with GYN cancers and they could not get treatment because the chemo drugs were not available at all in the United States, which is just crazy to even consider. But that was a reality that we were facing. And I will say that our pharmacists and our institution really pulled together and said, okay, let's all put our heads together. Let's think about what are all the sources we can get done? What are the drugs that are there any substitutes? Can we use this? Can we dose reduce a little bit here? Can we give full dose here? How can we take care of all the patients? And it really was a huge team effort to get that done. And I'm so thankful we're on the other side of that. But I was also very grateful to be in a place that had a team that supported us through that.
Yes, absolutely. Especially with these types of illnesses, time is of the essence, and anything you can do to save minutes, days, weeks is helpful to the big picture of treatment. Yeah. I'm glad you mentioned the clinical trials available at St. Dominic's, as well as the advancements in care, particularly with molecular level insights into the root causes of these cancers. Are there any emerging treatments or exciting developments in this field that you're particularly interested in, or that it might, be coming to St. Dominic's someday soon?
I think the reason I really wanted to do clinical trials is because we're here in Mississippi. There are wonderful people here who need good care. And so having these trials open means that I have access to drugs that we can't get otherwise. And so things like antibody drug conjugates and immunotherapies, and how can we combine immunotherapies with our current chemotherapies, and how can we pair new antibodies with old drugs that can then target different molecular pathways. And so we can stop those cancer pathways. And, being in an institution that lets you do clinical trials really helps you stay up to date. And, I'll have, hey, let's have the representative from our newest trial come in and they'll sit down and go through, okay, here, doc, let's look at these trials. Let's see what's out there and what you are interested in, what fits your patient population best. And I think it's really important. And as we've focused a lot on diversifying clinical trials and how can we make sure that some of our marginalized patient populations are included in trials, that fits with our mission here. And really my goal of making sure that all the women in Mississippi get the best care that they can and have access to the most up-to-date treatments that they can. And so, and another thing that's important is when these trials are run, in New York and California, in Washington, those are different patient populations. And those are not our patients here in Mississippi that drive 3 hours away, that live in the Delta where they cannot physically get here. And so having a place that lets us think a little bit outside the box and being able to offer new therapies to these women is very exciting. So immunotherapy, I think, really has revolutionized endometrial cancer treatment, cervical cancer treatment, pairing different molecular targets with antibodies or antibody drug conjugates. That's been huge over the last year for ovary cancer, folate receptor drugs, and really just getting to the root cause of why these cancers happen, and then utilizing some old drugs, some drugs that are used in other disciplines, but figuring out that even though it started in the ovary, it has the same signature as a lung cancer, as a renal cancer, and so we can use those drugs that worked in those solid tumors for our tumors too. So it is a lot to keep up with, and it changes like every month. There's something new I need to think about or learn. But I think that's part of what makes it exciting, is that we are not stagnant. And the more we learn about why these things are happening, the more we can target and the better patient outcomes we can get.
That's great that we're able to offer so much more to local patients in Mississippi because of that. And coming back to what we had mentioned a little earlier, that certain health issues are more common in the South. And by testing for these things in the environment that people are living in and that are close to where you are treating them can provide a much more tailored care.
If we're not doing the trials, then we don't know how those patients are going to respond. And so that's supposed to be number one. When you look at a clinical trial as a physician, you look at something and you say, okay, how was the study done? How did they design it? What were their outcomes? What's their methodology? And then to know that you can apply that to the patients you treat. And so if my population is 65% Black, but the study only included 4 Black patients, how can I apply that to my population? Do we know that still works the same? Do we know that those patients respond as well as those did? We don't know that. And so we have to be able to enroll them, and we have to be able to meet specific challenges that come with, socioeconomic hardships or distance or whatever else it is that keeps people from being able to get their treatments.
Absolutely. Some of these factors are specific to Jackson and Central Mississippi, which makes it even more important to consider them in treatment. And it's so important we're considering those things for sure.
Yeah, absolutely.
Is there a patient story that you can share with us whose journey through treatment or who you've encountered that had a significant impact on you?
Oh, gosh. There are so many. One of my, one story I tell all the time is, so this was a patient who had vulvar cancer and, came to me as pretty advanced stage. She actually, had so much pain she really could not sit down. We did surgery, could not get it all. Really, it was just more of a palliative procedure. We did some radiation, and this has been several years ago. And so we were kind of doing all the stepwise things that would be recommended. So we did surgery, we did some radiation. She actually had some disease show up in her lungs shortly after that. And she got a little chemotherapy, and then immunotherapy came out. And I said, all right, well, I hadn't given this to anybody, but I think you're a candidate. And the approval was actually for cervical cancer, which is not what she had, but those come from the same thing. They have very similar molecular targets, just like we talked about. So I had to reach out to the company and say, look, she's vulvar cancer. I know that's not what the approval is. Her insurance denied it. Can you help us? Yeah, that approval is going to come soon. We can help you for now. So they helped us get the drug, and she had a complete response. And so the disease that she'd had in her lungs was completely gone. Her vulvar disease was gone, and lived 3 years on getting a drug, an infusion once every 6 weeks, which really is pretty tolerable, with no evidence of disease. And so, it's just amazing that we're in that kind of era where, where I can do that and where I can see those things happen. And I have she's 90, maybe close to 90. I operated on her 2 years ago for endometrial cancer. And she said, oh, I don't know if you can operate on somebody my age, doc. And, it was the same thing where I said, who do you live with? Oh, I live by myself. Okay. Where do you get your groceries? Well, I drive. Mm-hmm. Do you go to church? Oh, yeah, every Sunday and Wednesday. Okay. Who takes care of your flowers for you? Well, I do. Okay. I think you can have surgery. Oh, I don't know about that. It's like, well, I think we can, and we'll stop your bleeding. Okay. Well, and it took me, I think I saw her. Let me think about it. Let me talk to my family. Okay. Yes, ma'am. Sure enough, she had surgery. She comes in now 2 years later. She's now 90. She has no evidence of disease. She went home the same day of surgery. She's done great. She had a stage 1 limited cancer, and she's done. And she's not had any more bleeding, and she's got no evidence of disease, and she's still living alone and driving herself to the grocery store. So, just a simple, okay, you're 88. Okay, let's see how this goes. All right. But I have a lot of joy in, my job, and in, even in, some of my, what people would consider bad outcomes, or, helping people at the end of their life. There are so many patients that I have had to sit down with and say, this isn't working. And you get to make decisions now. And I have these drugs that really don't have much chance of working, but I'll give them to you if you want them. Or you can choose now to not, and you can choose now to not be in the hospital and not be on therapy and not feel bad and be home with the people you love, and go to the beach if you want to go to the beach, and go fishing if you want to go fishing, but you get to do what you want to do right now. And that's hard, but those are the people that impact me. And it's hard, but beauty, It's a very special time in a family's life, and to have the privilege of holding their hand through that really means a lot to me.
On the topic of support, what advice would you give to women currently undergoing treatment? How can their families and loved ones best support them?
So I think this is super interesting. There's actually data out there that says people who have a positive attitude and people who have good support systems do better. And that is actual data out there that exists. But anecdotally, when I have patients who come in and they're just defeated and they are, I can't get treatment, doc. I just can't do it. I'm not doing chemo. And those patients really don't do well. They'll read every single bad thing that can happen and it'll happen. But when I have people who come in and they say, okay, we're doing it. We're going to fight it. We're going to move forward, and you tell me to do what to do and I'll be here. And even sometimes when people don't feel good and they say, okay, I need to take a minute or I need to take a break. It's really always surprising to me how a positive attitude or family support is huge, or not necessarily family. Maybe you have a friend, maybe you have a church member, maybe your church bands together and says, hey, we're going to provide meals for this person, and just take that off their plate. And I think that women, most of us, myself included, have a hard time asking for help. We are so used to taking care of people, to taking care of everything, and just, having all the details be under our cover, that I do have to tell patients a lot, this is not the time. Okay. This is the time to ask for help. Let yourself be helped. Let other people take care of you right now. Take a step back, take a nap. Don't look at your laundry. Don't think about the dishes. Let somebody else do that for you. And I think it sounds silly almost for people to have to say that to somebody, but most women are so used to being the caretaker that flipping that role and having to be the patient is hard for them. And so that I would certainly encourage people. I tell people all the time, let them take care of you. Ask for help. It is hard. And I sometimes have to say, you're not going to be like this forever. Like, this is a limited time that you are going to ask for help. And after that, you don't have to ask for help, but for right now, do it.
That's great advice. Sometimes we need that permission to ask for help. And I'm curious, what role does a positive mindset play in healing, and what other resources might help patients through this process?
We have a mentorship program here that Nukes has helped us support. We got a grant a few years ago called the Woman to Woman Mentorship Program. And what that does is it essentially matches a newly diagnosed patient with a patient who's been through it. So we have a set of mentors who have been through some training and are able to, and however those patients want to communicate, they can do text only, they can talk, they can get together. And I've had several women just make great relationships with each other that have been through it before. I'd say that's been a big part of how we support people too.
That's wonderful to know that that program is available.
Yeah.
And so before we wrap up, is there anything else you would like to share about gynecologic oncology that our listeners should know?
All right. So a couple things. So one, make sure you're getting your screening. So if you're not in need of a pap smear, go get it done. If you need an HPV test, go get it done. Have an advocate, be an advocate for yourself. Have a provider that listens to you, that understands where you're coming from. If you haven't been vaccinated for HPV, if you're under the age of 45 or you have children who are under the age of 45 or friends or family, get them vaccinated. And I think that's it.
That is the perfect elevator pitch. Thank you so much for this insightful conversation, Dr. Haygood. We really appreciate you sharing your time and expertise with us. We'll have everything Dr. Haygood mentioned, along with other helpful resources and ways to connect with cancer care teams across Louisiana and Mississippi, linked below. Thanks for listening.